Welcome to today's webinar entitled Trials, Tribulations, and Triumphs with LTBI, sponsored by the Southeastern National TB Center and the NTNC. Today's speaker is Dr. Ellen Murray. Dr. Murray has her Ph.D. in public health and has extensive experience in corrections and TB. She worked as a corrections nurse in jails for 17 years with experience in infection control, risk management, as an administrator, and also working as a staff nurse. She also worked as a nurse consultant for the State Health Office in Florida, all the correctional facilities in Florida, which includes Federal Bureau of Prisons facilities, state prison, local jails, juvenile facilities, and an ICE facility for over 10 years before coming to SNTC. Today's moderator is Dr. David Ashkin. Dr. Ashkin is medical director and co-principal investigator for the Southeastern National Tuberculosis Center. As the current medical director of the Florida Department of Health's TB program, Dr. Ashkin is responsible for the medical management of all of Florida's TB patients, including those most complex cases, which are hospitalized at the state's 2 contracted TB centers units. Dr. Ashkin is a board-certified pulmonologist and intensivist who trained at St. Luke's Roosevelt Hospital in New York during their outbreak of multi-drug resistant tuberculosis and did his pulmonary fellowship at the University of Miami during their outbreak. He has published extensively on the care and treatment of tuberculosis. Dr. Ashkin also serves on Florida and national advisory panels for controlling tuberculosis and was instrumental in restructuring the Florida TB program, Florida TB System of Care, to better address TB elimination in the state. Dr. Ashkin is currently on the faculty of the pulmonary departments at the University of Miami, University of Florida, as well as Nova/Southeastern Medical Institutions. Now we'll turn over to our presenter, Dr. Murray.
Welcome, everyone. The National TB Nurse Coalition has developed webinars throughout the year, and when they asked me to do something, the first thing I thought of was TB infection, because there are so many trials and tribulations with it, and there are some triumphs. So to me, this was a really important piece, because if we are to ever get to elimination of TB, this is going to be probably the most critical. And we'll see that in a minute. All right, we've got some objectives here. I'm so grateful to be doing this with Dr. Ashkin, because when I worked in the jails, they kept telling me I knew everything there was to know about TB, and I had cases upon cases and LTBI, positive TSTs, and so I was always dealing with TB at some form or another. And then when I went to the State Health Office and started working with the TB programs there, I learned I knew practically nothing about TB, because the nurses out in the health departments, let me tell you, they eat, sleep, and breathe TB. And I learned so much from them, as well as from Dr. Ashkin and Dr. Lizardo, and now being here at the Southeastern National TB Center, I have just, it's amazing to me how long my career has been, and I'm still learning to this day, and I hope you will too. So at the end of this presentation, we're going to try and help you to identify those high-risk patients, and you can probably tell us what, better, who they are, and begin, but not only begin complete treatment for TB infection, because we want to prevent progression to active disease, and evaluate those real case scenarios dealing with challenges, because I like to teach that way. It's one thing to read a guideline, but how do you apply it? And that's what we're going to talk about today. There is an estimation, and many people quote this all the time, 1/3 of the world's population is infected with TB. Well, that's about 20 years old. The study that was recently done in 2016 actually was done in 2014 but published in 2016, The Global Burden of Latent TB Infection, a re-estimation using a mathematical model, really identifies a few more people, globally 1.7 billion people with LTBI. And addressing the latent infection reservoir is absolutely critical to achieving that TB elimination. Again, in that study, it really did demonstrate in those third world countries that only takes a plane ride to get over here, several things. And the proportion of population from the World Health Organization's region that's infected, according to this study, recently infected, and those recent infections have a lot of INH resistance. With a 95% certainty, you can look at this and see, you know, what's the proportion of people that might actually go on to active disease. That's a lot. They've got a lot of children, a lot of HIV in these countries, so they may be your next cases of TB. When we think about TB, we have to think about, how did that person get the TB? Well, every single case of TB was once a contact. And we kind of forget about that sometimes. How did they get it? Well, I have no idea is usually what their answer is. This is so important to remember, because sometimes people get complacent and go, oh, it's a positive skin test, but no big deal. We're going to talk a little bit more about that. And of course, in the population that I like to teach, our corrections population, that can be a really important piece that they forget. So who's really at risk for progression to active disease? Well, here the list goes on and on: contacts, HIV, other immune suppressed, the homeless, et cetera, et cetera, et cetera. And there are actually those who are locally defined. Your health department would be the best resource for identifying those high risk in your area. Because sometimes we have people that are, like we have groups that come in and settle in one particular area. I have to include a plug for my favorite subject, TB and corrections, as that's one area where all of the above, everybody on this list, can be concentrated into one person. You've all seen this slide, latent infection versus TB disease, and it's really brings it out in the CDC self-study module number 3, targeted testing, and the diagnosis of latent infection and active disease, or TB disease. The difference in TB and LTBI, in its simplest terms, latent infection, you can't spread the bacteria. They generally don't feel sick. If they do feel sick, something else might be going on too. But they have a positive skin test or a positive IGRA and a negative everything else. No symptoms, their chest x-ray is normal, they don't require isolation, they're not an active case. But active cases, and those are the people who progress from infection to disease, they have large amounts of bacteria in their body. They may or may not feel sick at the point where you're seeing them. And usually they have a positive skin test or blood test, but not always. They could possibly have a negative or 0 millimeters TST or negative quantiferon. And Dr. Ashkin later on might talk about, I'm hoping he will, and I'm pretty sure he will, talk about the quantiferon and the specificity and the sensitivity, as well as T-spot and TST. They definitely need treatment for TB disease. But you notice I didn't say they definitely need treatment for LTBI. And it says consider LTBI treatment. I think these are the people that if you've got positive tests, you need to do a risk assessment and make sure that they're not going to be your next case of TB. The people with active disease, you are going to be reporting them as a TB case. You want to make sure they're isolated, they start the right treatment, and you get sputums for smear and culture. And generally, their radiograph may be abnormal. So we have some challenges for completion of therapy, and a really interesting article that was done by Randall Reeves, Bob Belknap, and some others has opportunities and challenges. It's really about those challenges for latent TB infection before they get to the point where they're actually active disease. There's barriers to completing a course of treatment. The length of the treatment is definitely one of them. And medication interactions. We're going to talk about those medication interactions later on in this webinar, so we're not going to focus on that right now. But when you have latent TB infection, you don't really feel sick. So why take medication? That's going to make me sick. These are some important points that came out in this. So how do you get around that? And hopefully the rest of this webinar will be talking a lot about that. Not only does the patient have side effects from the medications, now we're asking them to take something that even if they didn't have side effects, we're going to give them something that's going to make them sick. So there's real barriers to completion of treatment, especially early on. And early on is when you see a lot of patients who will stop their medications. How do you get through that to get them back to being able to take the medication to get through that? So here's where I want to also put in another shout out for our TB is the Least of Their Worries webinar series. We're doing a lot with many of the challenges around medication interactions and some of the challenges such as mental illness or diabetes, all of these different issues. And those are in each webinar, and those are all on our SNTC website. And I hope you'll take some time to enjoy them. If you missed the live version, the archived versions are also available on the SNTC website. So there are some shorter, better tolerated regimens. You want to target those high-risk individuals, and that's why I'm really excited about the 3-HP. The isoniazid and rifapentine once a week for 12 weeks. It's been instrumental in getting folks through therapy when they may not have otherwise. There are some issues. The recommendations it should be part of every primary care setting for latent TB infection. Your practitioners out there all see these patients, and they may be diagnosing latent TB infection, but some of the challenges are what happens to them. They don't always get reported to the health department. And so doctors and nurses and practitioners generally may not realize this person is at a higher risk because they don't ask some of those pertinent questions that the health departments do. You want to target high-risk individuals, and there is absolutely a need for shorter, better tolerated regimens. The challenge comes into play. We don't have a biomarker for the inability to predict risk for a progression to active disease. So I want to talk about some cases, and I'm going to have Dr. David Ashkin actually help me with these cases because he says it so much better than I do, and I can't tell you how many times I used to call him on the phone, no matter what time of the day or night. He was always there, and I just am so grateful to be working with him. So the first patient, patient number 1, 36-year-old female from the Philippines. She was a recent arrival in the US, qualified as a B1 because overseas her chest x-ray was abnormal, but no results. It just said abnormal. The sputum cultures were all negative. times 3, and so she was allowed to enter the US as a B1. Her current meds, INH for 9 months, and she started that when she first got to the US. Her liver enzymes were normal, and her chest x-ray at the health department showed no evidence of TB except old calcified granulomas. Sorry about that. So after 2 months on INH, her liver enzymes start to climb a little bit, but she's completely asymptomatic. Her AST is 66, her ALT is 114. So we're going to do a little quick poll to see what you think, and then I want Dr. Ashkin to come in and talk about what some of the responses are. So the poll initially, if we can, is she at risk for active disease? Yes, no, I have no idea. Go ahead and we'll start that poll.
Ellen, good afternoon. How you doing?
Hey, Dr. Ashkin, you are there. I'm doing good.
Dr. Ashkin. Ellen, I don't remember the last time you called me Dr. Ashkin.
I'm an old woman, you know, doctors.
I'm listening to you tell everybody like how we had, you know, how you enjoyed work with me. You could tell them the truth now. It was pure torture. I mean, wasn't that really it? No, you know.
Well, kind of. I was in jail, so you couldn't touch me.
So, you know, first of all, it really is my honor to be here today. And Ellen, thank you for asking. And I always enjoyed working with you. And I'm not so sure who was doing the teaching or learning between the two of us. I would just like to say, I think we always learn together, and that's been the great part. So right now, I mean, everybody's, at this point, about 80% of people are saying that she's at risk for active disease. And I think that's a great question. I just want to go back for a second and, you know, discuss some of the stuff that Ellen talked about, where Ellen talked about, like, the newest data, and, you know, data is always changing, and the world is changing, you know, but suggests that 1/4 of the world is infected with TB, and that's huge, you know. But I think the most important thing to remember is even though 1/4 of the world is infected with TB, the vast majority of people who have TB in their body will not develop disease. Only about, as people on the phone know, only about 5 to 10% of all people who have TB in their body actually develop active disease. And it's a small percentage, but because the number is so huge, about 2 billion people, when you talk about 5 to 10%, you're talking about hundreds of millions of people who develop active disease. And that's why we need a way to try to figure out who's going to develop active disease, because I don't think we could treat everybody who's infected, and we're going to try. But I also don't think that everybody needs it. You really only want to give medication to people who need it. So you're really always looking, as Ellen said, for biomarkers. And there really is a lot of research being done right now trying to find biomarkers, something that would say not only is this person infected with TB, but you know what? The TB is starting to become active. We need to do something. And, you never know what's going to happen. I'm really, one of the things I'm thankful for is we have some amazing people out there right now doing research. But right now, we have to rely on risk factors. What makes your chance of going from infection to disease? And as you know, as Ellen said, what infection is, that those are people who have TB in their body, but their immune system is able to keep it in check. And it's when something happens to your immune system that doesn't allow the body to keep TB in check anymore that it starts to grow. And those are things like factors on your immune system, like, HIV, cancer, drugs that lower our immune system, both prescribed drugs and illicit drugs. Nutrition, as a matter of fact, in the world, it's believed the leading cause that makes people go from infection to disease is actually protein malnutrition. We talk about things like recent arrivals. For whatever reason, people who come here from other countries, if you're foreign-born, you have an increased risk of being infected with TB, but not necessarily an increased risk of developing TB unless you have other conditions, including recently coming here. No one's really sure why, and no one's 100% sure exactly how long that lasts, but some people talk about the stresses and stuff. So I think in this case, you're looking at somebody who is otherwise healthy, at least from what they're telling us, but she is a recent arrival, and that's why I think many people here appropriately said, about 80% said yes, they feel that she is at risk for active disease, and I agree, and that's why we do have a screening program for people coming in as refugees or immigrants legally to look at, you know, are they at risk and who's infected and try to get them on treatment. So, Ellen, I think I'm with everybody there. I think that I agree that she is at risk for potentially developing active disease, and putting her on INH is probably not a bad idea.
I agree, Dave. I agree. And as you know, one of the things that, as a former infection control practitioner, one of the things I look at was stress. And stress actually plays a major role in your immune system. And it can depress the immune system very, very easily. So there have been study upon study demonstrating that. It's quite interesting. So we have another polling question. I want to ask, should the patient be on medication? So again, let's look at that.
So I think, Ellen, what we're saying is initially, right, is that, you know, we think that she's at risk, and if she's at risk, is there something we can do to prevent it? Again, the concept of latent tuberculosis infection is that the person has live organisms in their body. And as long as they have live organisms in their body, there's a chance that those will multiply and make this person sick or turn into what we call active disease. We're relying in most people on their immune system to keep it in check. But wouldn't it be cool if we could kill those organisms so this way the person doesn't develop active disease? And that's the whole idea of treatment of latent tuberculosis infection. Give individuals medications before they're sick. When there's only a few organisms in their body, give them medications to try to kill those organisms to then decrease their risk of ever developing active disease. And what we're seeing here is first of all, I want to thank everybody for voting. I mean, I am really impressed. 65% of people are voting. You know, voting is a privilege and it's an honor. So thank you for doing that. And we really appreciate your participation. That's amazing. But yeah, 95% of people are saying that they feel that that she needs to be on medications, and some people are saying no. And I just want to address that because, you know, again, I think the people who may be saying no is they're saying, you know, I'm not so sure this is enough risk, you know, for her to be on medications. But I have to be honest, as the medications are becoming more effective, as we're realizing that the interventions we've done up to this point have not really gotten us close, are not really able to achieve our goal of eliminating TB. I mean, studies have been done recently to look at modeling to see if we just continue to treat active TB, will we be able to eliminate it? And the answer is clearly no. And more and more evidence is supporting that the only way we're going to take the next steps, and why the big pushes from the CDC, is try to identify people who are infected, especially those who are at risk, and get them on therapy. But I want to emphasize something I want to say over and over again today. You know, I think we put way too much emphasis on finding out who's infected with TB. But what's the use of finding out who's infected if we don't make sure we start people on therapy and complete the therapy? And that's the challenge. Knowing somebody's putting a PPD on somebody or doing an IGRA has never stopped them from going on to active disease. We need to complete the task. We need to make sure we start people on therapy, and most importantly, that they complete. So, Ellen, at this point, I see that 95% of people are saying that she should be on therapy. So I think we agree. Right, Ellen? What do you think?
Absolutely. And I many times you'll hear me say it depends, because you want to see, does she have any other risk factors? But just the fact that she is recently coming in, she's got a lot of stress on her because she doesn't have a place to live, or you don't know. You have to ask all those other things. So those 5% that are probably saying no, they probably are thinking in their minds, I want more information first. But I'm with you.
But I think the key always comes down to, because I want to emphasize this, and I think it's important, you always have to weigh the risk of developing active disease versus the risk of getting adverse effects from the medications. And that's why not only do we need medication that we can complete, but hopefully those that have less and less adverse effects so that the risks become less and less and become much more evident that the benefits of taking the medications outweigh those risks.
Absolutely. And I am so glad that you added not just starting them on treatment, but completing that treatment. I liken it to if a surgeon goes in and does a great job taking out whatever needs to be taken out, but forgets to sew them up, what good is that surgery? It's almost the same thing. I mean, if you don't complete, the starting them is just that. You've started, but you haven't completed it. So,
right. And I always,
yeah, go ahead.
we always used to say in Florida, you know, that the CDC, back when they put out their targeted testing, said the decision to test is the decision to treat. Meaning that if you were going to test somebody, you got to be ready to treat them. And we always added and complete. And I think that should be the decision. That should be the statement. The decision to test. If you're going to test somebody, be ready to treat them, and then most importantly, or as importantly, be ready to complete them. Yes. So I'm sorry, Ellen, go ahead.
No, that's perfect, because that's been my motto forever. So lastly, would you hold meds, continue meds, consider other regimens, identify other causes? I'm going to go ahead and ask you, Dave, would you comment on that? I believe.
Yeah, so I don't think. Yeah, I don't think you mean lastly. I think the question now is what we all get faced with. You know, okay, great. You know, we've now started the person on therapy. We're doing good, and then something like this happens. And as Ellen said, you know, one of the issues comes down to is that yes, it's important to start meds, but then we really, above all, want to do no harm. Because again, you know, these patients are asymptomatic. They only have about a 5 to 10% chance, if they're otherwise healthy, of developing active disease. The last thing you want to do is start running into issues. And when you use a drug like INH, as individuals know, depending on the study, depending on the age, you know, for most individuals, especially young individuals, the chance of getting hepatitis from the medications are less than 1%. But as you get older, as you start adding in other diseases like viral hepatitis, liver disease, illicit drugs, you know, other medications the person may be on, the risks become greater. And as you can see in this individual, now her AST and ALT are elevated. And again, you know, if you look at it, if you assume that the higher limit of normal is about 40 to 50, if you look at that ALT, it's about 2.5 times above normal. And normally what we would say is that if you're 3 times above the baseline, or upper limited normal, I should say, and you're asymptomatic, we would continue to give the INH, right? But if they became symptomatic, meaning if they were starting to have nausea, vomiting, or if it became 5 times above the normal or the upper limited normal, then we would stop the medications. And I want to step back a second, because I think what's really implicit here is to realize that nowadays, if the person's otherwise healthy, we wouldn't even be doing transaminase monitoring. I mean, because you know, most individuals who have an elevation of their transaminases, first of all, it's relatively, like I said, rare, and it's usually asymptomatic. There's not much to do. So the current recommendations actually are, if you don't have any other risk factors, not even to do blood tests or AST, ALT while you're on INH. And the other thing you would do is clinically monitor. And I can't stress this enough. I think the most important thing we can do is ask the patient, are you having symptoms? As a matter of fact, I think when we start therapy, we should tell them up front that if you have any symptoms of nausea, vomiting, dark urine, light stools, loss of appetite, to immediately stop the meds and tell your healthcare provider. But clinical monitoring is as important, if not more important, than actually blood test monitoring. But traditionally, if you do have symptoms, or if you are monitoring, if it's 3 times above normal and you're asymptomatic, we continue it. If it's 3 times above normal and you're symptomatic, we would stop the medication. And if it's more than 5 times above the upper limits normal, like I said, that's usually about 40 to 50, So 5 times would be around, depending around about 200, 250, we would stop the medications no matter what. So what you're seeing here is that 40% of people are continuing the medications, and I think they're also, and I know I hate these polls. I don't know about you, because you can only answer one, and in most of these, there's always more than one, But I think another 34%, are saying consider other regimens, and we're going to talk about that in a second. Regimens like the rifamycins or 3HP. And then I have to say, I love, first of all, you guys are amazing. First of all, you keep voting. That's outrageous. Thank you, thank you, thank you. You're sharing your opinions would help us, because I think you'd agree it's easier for us when we see what you're saying, so we're interacting. I feel like we're all together, which is cool. But the bottom line is that 22% said identify other causes. And I actually think that all of those answers are correct. Whenever the LFTs go up, Ellen, I think you'd agree, the first thing we always talk about is don't always blame it on the meds. Make sure it's nothing else, right? And, do an ultrasound, do viral hepatitis. Make sure they're not on any other medications, including illicit medications. Herbal teas are always there. So I think that's a great answer. Matter of fact, I think that may be, and again, I'm biased, but I think that's the best answer, actually. But then the next thing is I think they're right. I think you'd continue the meds. She's asymptomatic, but you always want to have you always want to know what your next step is. And there's no doubt that going to a rifampin or a rifamycin or 3HP is definitely an option. Ellen, I don't know if you want to talk about it now or you want to add, but I think it's really important to talk about the whole use of INH, because let's be honest, this question is dated. I'm not so sure many of us would have even used INH in a case like this. What do you think about that, Ellen? Is that where you want to go now? Or
no, I actually, we're going to talk about that in a little bit with another case.
Okay.
But
right.
Yes, one of the things I want to really address are the other causes. What are some of those other causes that would make you stop and think? And so, as you've, very nicely pointed out, viral hepatitis, structural issues, other concurrent medications, all of those play a big role in what's going on with this patient. Why are her liver enzymes, becoming elevated? So, do you want to comment a little bit?
Especially in a middle-aged female, things like gallstones are very, very common. And, that's why we always like to do an ultrasound if the person is continuing to have an increased LFT, especially if you stop the medications and it's still staying up. I mean, I think you want to rule out other things. And the reason you want to rule out other things like that is that there's something you can do about that, and there's ways around it. So structural, issues, you also never want to miss something like an obstructed duct, a tumor or anything else like that, much rarer. But, it's always a good idea, in my opinion, especially if you have other indications like the total bilirubin's up, the alk phos is up. We may want to think about things like stones. And then, like you said, Ellen, I think viral hepatitis is, especially in our population, especially if you're looking at things like you were saying, like corrections and stuff, depending on the population you're looking at, anywhere from 3 to 25% of those populations may be infected or co-infected with a viral hepatitis, including hepatitis B and C, depending on what part of the world you are and the risk factors. And the reason that's important now is that there's now, as you know, very, very effective therapies, especially for hepatitis C, that you can now use. The problem with some of those therapies when it comes to TB is that at least the new antiviral medications for hepatitis C, the newest ones, most of them are contraindicated when you use a rifamycin. Mm-hmm. So the debate in the LTBI world and TB world has been, do you treat the hepatitis C first prior to treating the TB? And again, a lot of that depends on, what risk factors the patient who's infected with TB has. Like, if they're HIV positive and they're infected with TB and they have a very low CD4 count, some people might want to treat the TB first, whereas if the patient is otherwise healthy, except the hepatitis C, some people may suggest that maybe you should treat or cure the hepatitis C first. And again, these are the things that I think we'll know a lot more about in the next couple of years.
Right.
But viral hepatitis is a very key given. And then last, you always want to be asking about medications. And at least the population that I treat, and many of us treat, cultural issues and, things like herbal teas, and with, new movements of, people believing that supplements are really healthy and there's no side effects to them. I think it's very important to not only just ask about what prescription drugs, not only what illicit drugs like alcohol or the opiates, but most importantly, what other, herbal or supplements are you taking, including, things like steroids and stuff. So I think that becomes very important.
Well, and I would also add, they tend to take things like anything organic. Many people think if it's organic, it must be good for me. And a lot of organic things can build up in your system as well. So you have to ask about anything that they're taking on a regular basis, not just the medication. So yes, I'm glad you pointed that out. Thank you.
And actually, if I can, just for 1 second, April has a great question, and I want to thank April for asking the question. But she's saying, which I think is great, she's saying, with the whole opioid crisis, the horrible epidemic that we're going through right now, and the increase of co-infection, how do you address the LTBI and the hepatitis C and, long-term methadone and Sublok, does that affect? And, while we're just talking about this real quick, and we'll have an opportunity to do it later, the answer is clearly yes. It all comes down to risks and benefits. If the person is very, very immunosuppressed, and you have to treat the hepatitis C, some people would argue that you either treat that first or use something like INH, which has less effects with the hepatitis C drugs. And same with the methadone and Suboxone. Like if you use the rifamycins, again, they interfere. So INH may be a better drug in those cases, except that just got to be careful of the liver enzymes. So I think that's a really, really good question. But the problem comes down to from a TB perspective, is as soon as you use INH, now you're talking 9 months, and that's the problem. So it's really a decision based on the patient and based on what is the biggest problem that we're facing with this patient at this moment and what needs to be addressed right now. And I think that really becomes the issue.
Yeah.
Great question. April, thank you.
Thank you, April. And we actually have an archived webinar on TB and the opioids. And you also did
and hepatitis C, yeah.
TB. Yeah.
Yeah, right.
So, yeah, I encourage people, go to that, because we're not going to get into the big meat of it, but those archived webinars really focus on those one particular issues, and there's so many. All right, let's move on to patient number 2, a 37-year-old Hmong female who was born in Thailand, but migrated to the U.S. at age 6. Her past medical history was she developed lupus. She's on azathioprine. Did I say that right?
Yes. Outstanding.
I know. And high-dose prednisone at 20 milligrams per day. And so, again, she's having some issues. She's 37, and her rheumatologist wants to begin her on Benlysta after he screens her. So he screens her. She's already had a positive TST. Quantiferon was indeterminate. The T-spot, however, comes back positive. And there's no complaints of any symptoms at this time. So she's got no complaints whatsoever, according to the rheumatologist. So how do you really screen for patients who are really immune suppressed? Well, you may want to do all 3 tests. And Dave, I'd really like you to comment on this, because this is kind of a little bit out of the norm, but we as nurses get faced with this almost every week.
Yeah, so I don't really think this is out of the norm, and I think it's an amazing question. And so let me start with something that I don't know about you guys. I've been doing TV for a long time, and I'm also a TV addict. I am addicted to TV. I admitted it now. Hi, my name is Dave. I'm a TV addict. But, I don't know about you, but, like, I can't watch. I used to watch TV to get away from from things, And one of the things you could guarantee 10 years ago is if you were going to watch TV, you wouldn't hear anything about TB, so I could get away, But now you can't watch a sporting event anymore or any event without hearing, ask your doctor to test you for TB. And I don't know about you, first of all, I wake up in cold sweats when I hear that at night. And this is the reason, because it's like, oh yeah, ask your doctor to test about TB, but how? And I do think, on the other hand, it's good that TB is on the TV, because now you've got doctors thinking. And this case is a classic case for me of my frustrations. So the way the TV commercials work is with all these new biologics, these tumor necrosis factor blockers, these amazing drugs that are saving people's lives. I mean, we're seeing miraculous treatments for autoimmune diseases like lupus and rheumatoid arthritis, Crohn's disease, psoriasis. It goes on, and it's going to get more. It's amazing, changing people's lives. But one of the things it does is definitely these drugs affect our T cells. It affects our body's ability to contain tuberculosis or any other intracellular pathogen. And because 1/4 of the world is infected with TB, we're seeing more of this. And what's happening is the good news is now rheumatologists, gastroenterologists, dermatologists, you name it, they're being trained that if they have to start somebody on one of these tumor necrosis factor blockers, one of these biologicals, that they should be testing before for TB. My frustration is notice that this patient who had rheumatoid arthritis was on azathioprine and prednisone, and a lot of prednisone. She was on 20 milligrams a day, and nobody screened her before. And that's not because you shouldn't have, because the recommendation is you should be screening anybody who's immunosuppressed. But now, because the gastroenterologist saw that commercial during his golf game, he's like, oh, now I need to, to screen. In reality, there's just no commercials that say, hey, if you're on azathioprine or prednisone, screen before. But I think in some ways it's good, but I want to emphasize this patient should have been screened before when they were on prednisone and azathioprine, and probably should have been on therapy back then. But what happened here is now that they're going to switch to a biological, and that doctor was listening to the TV because there's TB on the TV, suddenly he's saying, I think I need to screen. The question is how? And I think that's really the issue. Because one of the problems is all the tests we use, either the PPD or the tuberculous skin test, or the interferon gamma release assays, either quantiferon or the T-spot test, they all rely on our immune system to give us an answer. And the problem comes down to, specifically, they rely on the T cells, and the problem comes down to is when you're on azathioprine, when you're on prednisone, the whole idea of these drugs is to suppress your T cells, because the theory is it's your T cells that are attacking your body and causing disease. So all of these drugs attack the T cells to different degrees. The problem is when you're attacking the T cells, what do you think happens to our diagnostic test for TB? They also rely on the T cells, and they start to not work. So in a case like this, you may not be able to trust your results. And here's the problem. These are the patients we need to have the results. We need to have accurate results the most, because these are the patients that have the highest risk of going from infection to disease, or one of the highest risks. So a lot of people are now saying that if you have somebody who's about to go on one of these drugs, right, that you may want to screen them with all three tests. Or if you know they had a history of a positive PPD before, you're not going to take a chance. Just treat them. But what a lot of people are now saying is, let's start with the PPD or the IGRA, doesn't matter. And if that's negative, let's use another test. And many people are saying use all three tests. because especially in somebody like this who comes from a part of the world where TB is quite prevalent. Matter of fact, some people would even argue you don't even test it. I mean, if you have somebody who comes from a place of the world where 40-50% of the population is infected, places like Haiti or Cuba, that you may, and others, I mean, we can go on and on, you may just want to treat. But a lot of doctors, if they're going to start somebody on therapy, especially a lot of patients, want proof. So you're right, Ellen. The question is, you may want to do all three. I mean, if you look at sensitivity, maybe still debatable, because we really don't have a gold standard. We really don't know who's infected with TB. Remember, the only way you would ever really know who's infected with TB is if you took the person up, you ground them up and cultured them. And it's really hard to get volunteers for those kind of studies. So I want to remind everybody that we don't really know who's infected with TB. We have no gold standard. All these tests are correlated with being infected with TB. And it seems like the skin test is probably, or maybe the most sensitive, though it's somewhat debatable. So a lot of people would start with a skin test first, but as you know, the skin test has a lot of false positives, but in a population like this, you're not worried about false positives because you just want to make sure you don't miss TB. And if that's negative, some people would say you would go to either a quantiferin or a T-spot or both. And if any of those are positive, you would treat. We'll talk about what you would treat with in a second. But this is probably one of the most difficult situations. And that's why I wake up in a cold sweat at night when I hear ask your doctor, because that means that they're going to ask us. So we got to be ready and understand why. So what do you think about that, Ellen?
Well, this is one of the things that gets asked of me a lot, and I generally say, let's find out, because there's the specificity and the sensitivity is different in each one, and it all depends. I mean, as you know, the TST it all depends on how you administer, how you read it. There's so much variability with that. The lab tests, again, there's still some variability depending upon how you sent it and, all of those things. So one of the most critical questions that I always ask is, should this patient be on medication for latent TB infection? So that's something that we're going to look at. And it's either yes, no, or do we need to rule out active disease first? So I'm opening the polling questions again, hopefully. Maybe. There we
look
go.
at that. Ellen asked, and it shall occur.
It is really scary, actually, for me in technology.
Wow.
Yeah, because I'm always technologically challenged.
So first of all, again, Ellen, I want to say thank you guys for voting. It is amazing how many of you guys are participating. Thank you so much. So first of all, you're getting an overwhelming majority of people who are saying that we need to rule out active disease first. And, and I think this is kind of a little bit of a tricky question. I think we would all agree this patient needs to be on medications, but the question is how many? And isn't that really the question? See, I think one way to think about it, LTBI and active disease is they're a continuum. People who have LTBI have organisms in their body that we need to kill. People who have active disease also have organisms in their body that we need to kill. The difference is the numbers. It's all a numbers game. And I remember John Sababra, who was one of my mentors and I believe one of the great clinicians in TB, and we've had so many great clinicians in our history as a family. We're blessed to have so many amazing clinicians who took care of our TB patients and most importantly taught us. And John used to say all the time that more bugs, more drugs. And what he meant by that is that when you are infected with TB, you may not need as many drugs because there's just not as many organisms. So you can get away with INH alone. So what happens is as you develop active disease, you have billions and billions of organisms. And the more organisms you have, the more chances that you're harboring a resistant organism. So the only way to get rid of that resistant organism is by using more drugs that are effective against those resistant organisms. And that's why we start 4 drugs on patients who have active disease and may only use 1 or 2 when we have latent tuberculosis infection. So the answer here, it's a little tricky. Does this patient need to be on medication? Yes, but the question is really how many? Meaning, do we treat LTBI or TB? And as you realize, the only way we know is if we do a workup for active TB. So I think the key here is that every patient who is going to start on LTBI therapy, we must rule out active TB first. And the reason is if we don't, and we don't start enough medications, we're going to get more and more, we have the potential to get resistance. So we always have to, the challenge in this case, though, is where's the TB? You know, you've heard of where's Waldo. This is where's the TB. Like in our first case, if you're immunocompetent, like our first individual was, it's more than likely in the chest. Over 90% of patients who are immunocompetent will have TB in the lungs. As a matter of fact, one of the things I wanted to talk about was, remember, she had granulomas on the x-ray. And I want to put in a plug here. I think it's really important that you look at your own x-rays. And I know you're going to say, I don't know how to look at it. You do. And the thing is, the only way to learn is by keep looking and looking. And the difference is that granulomas, which are small little white dots on the x-ray, if that's all you're seeing, interestingly enough, there is no increased risk of getting TB if you have granulomas alone. And the reason is that that means that the TB is stuck in the walls of that calcium. It can't get out. You're actually safe. The problem is that people usually just don't have granulomas. They usually have other evidence of disease somewhere else where it can come out. But actually, a granuloma is a successful healing of an infection. But the bottom line is in that one area, not everywhere else. So always you want to look. So in somebody who's immunosuppressed, it's important not only just to do a chest x-ray, but also do a history. Make sure they have no other symptoms, no fevers, weight loss, or symptoms that it could be somewhere else, like back pain, or they're having diarrhea or whatever. So I think in a patient like this, the challenge is, the easy part is saying, yes, we need to rule out active disease. The challenge is knowing how to rule it out, meaning not only just do a chest x-ray, but also make sure the patient's totally asymptomatic. And if they are symptomatic, to make sure you're thinking extrapulmonary disease.
Good. And I just put this slide together very quickly, just wanted to make sure that people remember, always check for interactions between your medications. And not just what she's currently on, but the TB medications as well. Because if you're going to start her on RIF or INH, you want to make sure that this particular medication does not interfere with her other medication that she's going on, especially if they're going to be started on Benlysta or something like that. So which regimen
Ellen, I think
therapy would you use?
I think we need to go forward. I think we're still seeing the old slide, the poll slide. So if we can go forward.
Oh,
and while we're looking at the news, yeah.
Sorry about that.
And while we're looking, no problem. And while we're looking at that, Lisa asked a great question. She asked, if we're going to do all 3 tests, would we also do a chest x-ray? And Lisa, I have to say, personally, I would have a very low threshold for doing an x-ray, meaning that if that person said that I've been coughing, or, I'm having a little shortness of breath, yes. So I think, Lisa, normally we would start with three tests, but I think many people would also do a chest x-ray just to make sure that you're not missing some, especially if the person has any kind of symptoms whatsoever. So, Lisa, great question. Thank you so much. Yeah, I think we're having a little problem with the slide right now. I think we're back to. So let's go while we're waiting for.
Looks like we've lost.
Yeah, while we're going.
Connector.
Yeah, while we're waiting, let's just talk about what meds would you use here. So, again, I think in a situation like this, let's say the test, the PPD is positive. Let's say the X-ray is negative. Patient's asymptomatic. You don't have any evidence of active disease. You want to start them on therapy. And I think what becomes very important is which regimen and then when to start. And again, these are really hard things, and we really don't have definitive answers yet. We're still waiting for studies. But I think most of us would agree that we want a regimen that we can start, now, hopefully get them through relatively quick, and one that doesn't have much interaction. So like the problem with the rifamycins is that they can interact with prednisone or azathioprine, but especially prednisone. As a matter of fact, if I could make a quick plug here, whenever you have a patient who's been on prednisone before, or even some of our older patients who have maybe low baseline cortisol from underlying like Addison's disease that you're not even picking up, if you give somebody a rifamycin and suddenly they become very, very weak, if they start to have low blood pressure, abdominal pain, nausea and vomiting, many times you may have unmasked the Addison's disease, because remember that the rifamycins cause the increase metabolism of the cortisol. So that's something we see quite often, especially in our older patients. But in a situation like this, we got the slide back. Thank you very much. We talked about ruling out. Whoop, there it goes. We talked about ruling out, active disease. We were going to screen for TB with chest X-rays, and then, like we were saying, we want to look for interactions. And like we said, the rifamycins. If we were going to continue prednisone, the thing to do is just increase the prednisone dose. Luckily, the tumor necrosis factor blockers have no interactions with the rifamycins. So for somebody like myself, it all depends on when do we have to start the immunosuppression. If the person's well and we just want to start in the future, we may start that person on 3-HP, wait about a month, after 4 doses, and then start the tumor necrosis factor blocker. On the other hand, if the doctor tells me, you know what, I need to start now, this patient's really sick, we either start the two together, but that's a little risk, that the person can become immunosuppressed and develop TB, or use something like rifampin that's going to be given daily and give it for a week or two. I mean, we always want to try a month, but if we can't, we can't, and then start the tumor necrosis factor blockers. But again, these are really, really hard decisions. And in cases like this, we often would suggest that you discuss this kind of case with, with a quote-unquote TB expert. And we're lucky enough to have 4 centers of excellence around the United States. And these are their numbers. I think you guys know them. But these are the kind of cases I highly, highly recommend that you discuss, because the circumstances of the cases, the specifics, how serious is the underlying condition, often really dictates which regimen to use and when to start it.
So Dave, can you hear me again?
Oh, yep, I can, thanks.
Oh, good. I'm not sure what happened. I think we had a power failure. So
okay.
you love it,
Yeah, so next slide.
So our third patient, third and last, 60-year-old male, born in the U.S., chronic renal failure, pending a renal transplant, with an IGRA that was positive during a pre-screen workup. As you can see, on numerous meds, Plavix, Losartan, Humulin, Neurontin, has a lot of issues going on. Heart disease, high blood pressure, diabetes, lots of different things. So one of the questions that we're going to ask is, or what concerns would you have, Dave, as far as the effects of medications and rifampin and interacting with other meds?
Yeah. So first of all, I want to answer, because I just love that you guys were asking questions and communicating. I want to thank you guys, and I am looking, so I can't thank you enough. And Lisa had a great question that fits into this question really well. Lisa's asking, when do you have a cutoff for treating LTBI? Do you worry about, do you stop treating after the age of 65, 75, 85? Lisa, amazing question. And this is a classic case where it's not about the age, but about the immunosuppression of the patient. So this patient's 60 years old, but the problem is this patient's about to undergo a renal transplant. So no matter what the age is that if you now start to, give medications, or if you give the immunosuppressive medications without treating the TB, there's a real good chance this patient's going to get TB. So So what a great question. So Lisa, I'm going to answer you with the age part. I'm not as worried about the age as I am what is the associated medical condition. So if the patient's otherwise, let me give you an example. If the patient's like, 80 years old, otherwise well, and he knew that they had a positive PPD for 50, 60 years, and they live by themselves or in a small, I probably wouldn't do anything at that point because the chance of that patient getting TB is less than 5% right now. But on the other hand, let's say this person is now going to be living in a congregate living facility, especially, if they're going to go to a nursing home or whatever, then that's why we would reconsider, because that way, if that person got TB now and they were in a congregate setting, they would give it to everybody else. Also, as you can imagine, and I think you knew, usually individuals who might be going into a congregate, like nursing home, usually have other medical conditions that are lowering their immune system. So they probably also need it because now if they are on other medications that would lower it, or they have other conditions like renal failure, right, and they're in a nursing home, then you would treat. So it's not the age itself, but what condition. So let's get back to this case. The exact there is that here the issue comes down to is that the patient needs a renal transplant that's infected with TB. And the doctors know that if she gets the renal transplant, they're going to have to immunosuppress her, and the immunosuppressor, she is at increased risk. So a lot of transplant surgeons, interestingly enough, will not even do the surgery until you address the LTBI. Now, I didn't say you have to cure them, but most of them want the person on therapy pretty much for a little while prior to the surgery, if you can. Now, some of these surgeries are emergent. You can't do anything, so you address it after the transplant. But a lot of times the issue comes down to if you have a little time, you'll start treating the LTBI prior. The interesting part about INH and rifampin or rifapentine, which are the major drugs we use to treat LTBI, for the most part, they are not excreted through the kidneys. So we're relatively safe, even if she does have, a renal failure, is on dialysis. These drugs are relatively safe with renal disease and on dialysis. The biggest problem we have with the rifamycins is that the drugs we use to immunosuppress individuals, who are getting renal transplants, drugs like prednisone or drugs like tacrolimus or what we call Prograf or mycophenolate or Celsep, unfortunately, the rifamycins affect those levels. And what happens is it causes the immunosuppressive drug levels to be very low. And if they're low, unfortunately, what could happen is you could actually start to get rejection. So that's why I think the most important thing to do in these cases is either A, try to stay away from the rifamycins, but even INH has effects too. It's not as much with the interaction, but things like peripheral neuropathies that you can get with these drugs. Or most importantly, I think the most important thing is a close relationship with the transplant surgeons, and where we're both working together and using drug levels to adjust both the amount of immunosuppressive medications as well as the rifamycins. And that's what we usually do. We try to work closely when we can with the transplant surgeons so that we're monitoring both levels, so that we make sure, obviously, that the patient's organ is not rejected, and at the same time they're being protected against tuberculosis. And that's where these cases, I think we're seeing more and more complex cases like this.
Right.
But, in this situation. So I think, what we're looking here is when we talked about before, what are the problems with interactions with medications? And as you know, with the rifamycins, the biggest areas we're seeing this with is with the antiretrovirals, like the HIV medications, where many of them, such as like the protease inhibitors, will have issues with the rifamycins, where the rifamycins may cause their levels to be low. And certain medications like efavirenz, which is a non-nucleotide, or even now the integrase inhibitors, have less interactions. So we've been trying to use the integrase inhibitors or the non-nukes more with the rifamycins when we use them like 3-HP or rifapentine.
Right.
Big issue right now is anticoagulants. As you know, again, if you see a lot of commercials right now, and as you can see, again, I'm influenced by TV, but just when you think you see a lot of commercials right now for the biologics, boy, you're seeing a lot of commercials right now for the new oral anticoagulants, what we call the NOACs, or the new oral anticoagulants. And the problem with them is like drugs like Eliquis or Savacin and stuff, is that they all interact with the rifamycins, and they're all contraindicated right now. And as you know, drugs even like Coumadin have problems, and it's very hard. So anticoagulation with the rifamycins is very hard, especially when you're talking LTBI. And most of us are either using INH in those patients who are on Coumadin or warfarin, or on the NOACs, or we're now first starting to do like factor 10 levels, but that's really not ready for prime time yet. Yeah. But in most of those cases, we'll use INH. And then we've all known about the interactions with Latent and the fact that INH may lower the seizure thresholds where the rifamycins may interact. And again, I think a close combination and coordination with the primary care physicians is important. And just like we talked about now, the big issues with transplant are these immunosuppressive agents. And again, I think the key is really working close and doing drug levels to make sure we have adequate levels of both. Ellen, do you agree?
Yeah, oh, yes. And I think what I'd like to do, because we've got so many people out there that are still on the on the webinar, what I'd like to do is open the last polling question to see what would they do as the first next step, if you will. Evaluate for active disease prior to thinking about LTBI, check their liver functions, monitor clinical assessment, close coordination with the transplant team. And here's where I'm with you, Dave. I wish we could check several at the same time, because as we know in medicine, you may be doing 2 or 3 things at the same time rather than just one thing at a time. So let's open the poll and see where we're going with it.
I'll tell you, Ellen, I am really, really impressed with how good at test takers our audience is. I know that most of our audience are very good at administering tests, but boy, are they good at taking tests here.
They're nurses now.
Outstanding. Yeah. I knew they were great, and thanks again, for assisting, with this. It makes everything so much better. Thank you very much for your questions and answering the poll. So, Ellen, right now about 55% are saying that they would evaluate for active disease prior to LTBI. How could you go wrong with that answer? What a good answer, right?
That's absolutely what I would be doing.
And then the next thing was they would also be having a close coordination with the transplant team. What a great answer. How do you go against that, right? That's fantastic. And then 18% are, hey, I'd begin LTBI therapy prior to transplant if possible. So I think all of them are right. And how do you go wrong even with checking LFTs and monitor clinical assessment, including labs? I mean, they're all, like you said, right. But I think, as always, and I love the group here that, we're always thinking, always monitor for active disease prior. And the reason I'm saying that is, remember, all the other things and I'm not saying they're all good answers, they're all the right answer, but remember, ultimately as the TB team, our job is to make sure that person doesn't have active disease.
Right.
So I do agree with you. We're thinking active disease. Believe me, the transplant team is not thinking active disease. They're thinking about how do we immunosuppress this individual? How do we maintain the graft? They're doing everything they should be doing. Yep. So I love your answers that we should be also making sure there's no active disease. So guys, great work. Thank you.
And with this one, there is no wrong answer. Truly, there is
no. Definitely
not. So I did some digging to see what drug interactions on this gentleman's particular medications were. And the only things, like you said, with rifampin, big interactions, especially with the anticoagulant and the blood pressure medication. But the cholesterol meds, yes, that too, but not really that much. And then again, on rifapentine, not as much interaction, but you still want to monitor them closely. So same thing. So
and that's what I was gonna. That's what I was gonna say, Ellen. And that's how I wanted to get to this point, is that that's the big advantage of 3-HP over rifampin or rifamycin daily.
Right.
The rifampin daily, obviously, there's a lot more interactions with the drugs. Rifapentine, though it is longer acting, tends to have less interactions with most of the drugs. So more and more of us are really favoring the 3-HP when there's other drug interactions, though you still need to monitor them closely. The advantage of rifampin daily is that you get a steady state. So whatever effect you have, stays that way. It doesn't go up on Mondays when you give the rifapentine and back down. But in general, 3-HP seems to have less interactions than rifampin. So again, to summarize, advantage of 3-HP, much less liver toxicity. Less than 1% of patients who get 3-HP have a liver issue. So that's why if you have a patient who does have liver issues, it may be the better drug, or the better regimen, I should say. It's shorter. It's just once a week for 12 weeks. The biggest side effect and the biggest issue we see by far is this flu-like syndrome, and it could be quite severe. It's body aches, but some patients really start getting nausea, vomiting. They feel, they can actually become hypotensive. So it's something to warn the patients about. But, in general, 3-HP is very, very well tolerated, not 100, nothing's 100%. And most importantly, the completion rates with seeing 3-HP are way above what we saw with INH. We're seeing in programs in Florida and throughout the United States anywhere from 70 to 90% completion rates.
I know.
So we're really seeing very nice, and so it gets back to being able to complete. And what's nice also is that, in the beginning we were doing it by directly observed therapy, and to be honest, among our high-risk individuals in Florida, we still mainly do this by DOT, either DOT or video DOT, but there have been studies that showed that self-administered 3-HP, especially when it's utilized with some sort of reminder system, was non-inferior to DOT. I want to emphasize, non-inferior doesn't mean better, it doesn't mean equal. It means that within a 15% cushion, it functioned okay, as long as within 15% outcomes. So it is an option.
Yeah, and that's the beauty of 3-HP. The shorter duration has that greater potential for completion. And it's nice to be able to see an endpoint. 9 months of INH, you're thinking, okay, when am I going to birth this baby? But 3 months is really not too bad. And 4 months of rifampin, of course, is a little bit more difficult, but not as difficult. But again, if you want to comment on this slide, that 4 months of rifampin has a lot of interactions, doesn't it, Dave?
It does, and that's always the issue. But I will also say for rifampin, compared to INH, while there are more interactions, it tends to be very well tolerated compared to INH. And again, the completion rates are much higher, but you do run into more problems when the person's on other medications. Thanks.
All right, so there are some challenges to completion of therapy, and I think every nurse out there will probably be sitting there shaking their head yes, because there is a huge lack of understanding about TB infection. Not only on the patient's beliefs, which, why should they take meds? They don't feel sick. Or if they do take the meds, now they really don't want to take the meds because they weren't sick until they started taking them. So now look at what you're doing to me. If you're trying to do INH, that's probably not going to get them through. And as you said, Dave, we've got, the completion rates for 3-HP is so much better. But the provider beliefs, that I am finding providers have a very big lack of understanding about TB infection as well. In fact, as late as a couple of months ago, I had a doctor who said that the patient's not sick, why am I giving him LTBI meds? And it was clearly a patient that was born out of the U.S., and had many, many risk factors, including about to start on a biologic for rheumatoid arthritis. And, you know, that's something that, and he was quoting the 1996 guidelines. So these are some issues that I think, can you address the provider beliefs and see, you know, kind of what you've run into as well?
Sure. I mean, and I think, you know, physicians are outcome driven. Many of us went into the field because we wanted to take care of sick people. We wanted to make sick people better. And that's what we do. And there's great satisfaction. Everybody who's on this call, nurses, anybody in healthcare, know the satisfaction of making people better. You know, when it comes to preventive medicine, it's been very hard in this country to really sell it totally, because prevention, while, don't get me wrong, the big picture is key, you don't get that same satisfaction. So a lot of physicians, you know, are just not big fans of LTBI, to be honest, because they're not seeing somebody get better. If anything, they may see them get worse. And especially many of our physicians or nurses who are born outside this country. And remember, this whole idea of treating LTBI is more of a low-burden country premise, you know, like the United States, where we want to prevent the disease. In most countries, at least up until now, that wasn't their emphasis. So now if you have somebody who was brought up in a country where it wasn't the emphasis, then you come here, that may, even though you went to school and you learned about it and you understand it, it still may not be your number one priority. So I think the big issues from providers are, a lot of them just still don't believe in this concept. You know, it's still the same problems we're having with preventive medicine in general. And then B, I think the big issue also comes down is that, you know, the physicians are afraid of making somebody sick, of course. Above all, do no harm. And that's where we do need a regimen, or, you know, regimens that they feel comfortable in. If they don't have it, they're not going to encourage the completion of therapy, because if they have any side effects, it's going to be, yeah, just stop it. And I think that's really the issues, you know, and then, you know, obviously then just not going to see it through. So I think we need to really make physicians aware of what they're doing, and also obviously one, that the risks are very, very low. And that's what we ultimately need, a better regimen, or obviously for everybody on this phone, you know that no medication has ever eradicated a disease. There's only been two ways to eradicate a disease. One is good public health, you know, you cover up the swamps and get rid of yellow fever, or a vaccine. And ultimately, that is what we're going to need for these issues. But until then, you know, we need to really make sure that, you know, that people are understanding the goals of what we're doing.
So one of the things I want to get to these last slides, but because I want to leave some time for questions, because you got some great questions that are being asked. But solutions, there are solutions, and some triumphs. Get creative, but always make sure you engage the patient in their care, and that includes in corrections. I know many times we have a tendency not to include the patient because it's easier to talk amongst the case, you know, the whole team. But when you add the patient into their care, they can actually tell you how they want to finish their meds, or how they're not going to finish their meds, or whatever happens. And so you may need some behavioral modification, social services, educational programs. All of these things are predictors of TB infection treatment completion in the United States, according to this study done by Hirsch Moverman. And granted, this was inner city, but I can tell you this happens out in rural areas as well. I know of one nurse who was wonderful. She called me and she said, I'm trying to get this guy through treatment, and he's an alcoholic. What do I do? And together, we all got on a conference call, and he says, well, all I need is one beer a day. And so she actually made a pact with him and said, well, if I give you this one beer, you can't drink it for at least 2 hours after your meds, but I'll bring you 1 beer a day. And she got this guy through medication. Now, his liver enzymes were at the, didn't really get elevated that much. So she watched him closely, monitored him closely, and she was able to get him through treatment. I don't recommend that, but that was what he needed to get through his treatment, and got through 9 months of INH with that. So there are some things that can be done as long as you work with the patient, you work with others who have had these dealings. And we have in the National TB Nurses, we have kind of a listserv where we send a question out to our entire nurses in the United States, and we get a lot of these solutions back. So one more thing that this particular study looked at is who's more likely to complete and less likely to complete. And their study, interesting results, showed that if you're an alcoholic or you have drug problems, but you're in a treatment program, you're more likely to complete than those alcohol users who lived at home and weren't in a program. And if you were married and foreign-born, you were more likely to complete, or homeless and an alcohol users, than those alcohol users who were not homeless, or those foreign-born who were actually not married. Those are less likely to complete. And I would add one more caveat. I would add healthcare workers. We have a tendency in healthcare to not complete LTBI medication. And that's one of the things that we really need to remember. That's where we don't understand TB infection versus TB disease. And many times when I'm out there talking to people, they just don't quite understand the difference, that it is a continuum. It's not one disease versus another. It is actually a continuum along a line. And we really need to make sure that these people get through these treatment. If you're going to start them on it, try to get them through. One more slide, triumphs. We actually have had some shorter treatment times for LTBI therapy, the 3HP, the better tolerated regimens. Again, we have better diagnostic tests, but we need some biomarkers that are a little bit better with a higher predictive value for identifying who's at risk to progress to active disease. And we'll get to it eventually. Those more affordable medication regimens, those are so important. And I know several states around the United States are now going to charging the patient for LTBI medication, not for active disease, but for LTBI. And that can be a real problem if you don't have medication or you have other issues you have to deal with, like rent, food, electric. Why am I going to take some medication that's going to make me sick? So they kind of forget about that. And the availability of these meds worldwide is not there yet, but it's getting there. Dave, you want to comment just for a second about that?
Yes, as a matter of fact, one of the things I was going to say is that Isabel actually asked a great question about this, and I want to just comment, which is the question is like, do private insurance companies, with all the managed cares and stuff, do all of them cover LTBI? And the answer is no. They don't all cover it, and that is something that I think is important, like Ellen said, is one of our challenges. In my experience, most do cover it, but a lot of it is really dependent on the individual's medication, coverage plan that they have. And Ellen is right. I mean, it is always amazing to me that, I don't know how it is around the country, but many of the major, commercial, either supermarkets and pharmacies, like actually give away antibiotics for free. And I hate to say this, but INH and rifampin aren't two of them. And that's something that I think in the TB community we probably could get a little more proactive, but rifapentine is more expensive. I don't think that's happening in the next intro. But in short, no. The answer is they don't all routinely. A lot of it is dependent on on the coverage that the individual patient has. And then secondly, the next question is about health departments. And I'm sorry to say, Ellen is right again, due to financial restraints, not all health departments will provide LTBI for free. As a matter of fact, many health departments will have some sort of income-based reimbursement involved, and those are definitely barriers to us really being able to take the next steps towards elimination.
Yeah, and as many people know, nurses are great advocates. So I think the more we talk to these people and become advocates for these patients, we can actually get through to some of these folks out there that in the insurance company that are writing the checks for these kinds of things. And it's been done. It's not easy and it does take time, but in the end, it really does educate not only the patient, but the insurance companies and places like that. It really is a triumph. In a couple of areas, we've been really, really lucky. So with that, I want to thank Dave Ashkin, first of all, for all of his comments. And I want to turn it over to the audience. What questions do you have that we can answer? Dave, take it away.
Yeah. I mean, Ellen, there's a number, and unfortunately we only have a couple more minutes, but, and we've been trying, and thank you for all, we've been trying to get to the questions that are in the question box. I see there's also in the chat, but a couple that are there. One is that I think is really an important one, which is the question comes down to is, in the first case, there was a question of this patient came and she had a positive PPD, and they said, I thought they don't test with IGRs or PPDs outside the country, and that answer is actually partially correct. For most countries, it's recommended that anybody under the age of 14 between 2 and 14 get some sort of test, either an IGR or a PPD prior to coming into the country during the immigration process or refugee process. On the other hand, for individuals over the age of 14, especially from high prevalence countries, the PPD or IGR is only recommended when they have an abnormal X-ray or they're symptomatic. And even then, it's only if the country has an approved IGR, IGR approved test there or PPD. So that is correct. And most commonly, what usually happens is the person will come here after they've been screened with an X-ray, and then it would be recommended that they come to the health department to get a full evaluation. So you are right, it is not routine at all. The other question that was asked, if I may, is and somebody said, and I agree, is like, why don't we test otherwise healthy, and why don't we treat otherwise healthy individuals with a positive PPD? And I want to emphasize the point that, yes, we do. Again, I want to remind everybody of this statement because I think this is the key. The decision to test is the decision to treat and complete. So people with risk factors, they should be our highest priorities, and those are the people we should test first. But if we are going to test individuals, for whatever reason, if you're going to test them because they're going to a nursing home, or you felt that they were from a high-risk country, so you tested them. Once you've decided to test, you are right. That is the decision to treat and complete. So I think the real question is that a lot of us ask is, why did this person get tested? Was there a reason why this person got tested? But whoever places that test, once we know the results, you are right. That decision to test was the decision to treat and complete. And I think that's a very, very good question. I want to thank you for asking that. But again, the highest priority are those individuals who might have, as we talked about, might have issues with their immunity or whatever. But once you test and once you have a positive result, my opinion is you should sit down with the patient and go over their chances of getting tuberculosis, and their chances of getting it, any adverse reactions from the medications. And then if they agree, to start them. But again, the decision to test is the decision to treat and complete.
And I agree with you, Dave. And I know with the new healthcare provider guidelines that just came out, they're going to be slow, but educating people on changing their policies a little differently and just screening rather than testing everybody is going to be a really important piece that we look at. And I know corrections, I get these questions all the time. Well, so in corrections, we don't have to do any testing. Well, unfortunately, corrections is a high-risk population. And depending upon if you're working there all the time, you become a high-risk individual because of that, as well as other issues that are going on with you personally. So I think we're going to be talking about healthcare provider guidelines soon, not right away, and I don't know if SNTC will be, but I know NTNC was thinking about planning a webinar around that as well. So look forward to that. Any other questions coming in, Dave? We've got about 2 minutes left.
Actually, we have a ton of questions that are in there. They all came in the last couple of minutes, and I want to thank them all. But I think, Ellen, we are getting that we are at 2:30. So what I'm going to do, if it's okay, Ellen, is me and you, why don't we go over the questions we have there? If you don't mind, Linda, if you could just quickly print them, up for us, and then we can get back to those individuals who asked them. But I have 2:30, and I see that we got the it is time. So, Ellen, I want to first thank you. I want to thank you for presenting an unbelievable set of circumstances, and really, I think, helping us with trials and tribulations with LTBI. And then most importantly, I want to thank everybody who participated. And if I could just have one last thing to say is that if you have any questions, if we ever can be of any assistance to you, all of us at the Centers of Excellence, the 4 of us throughout the United States, we're proud to be part of the TB community. If we can ever be of any assistance, call your Center of Excellence. So, Ellen, I'm turning it over to you, and again, thanks.
Well, thank you, Dave. And if there's anything I've learned, you never have one last statement, but that's okay. I can't thank you enough for all of your comments, and for everybody that's on the phone as well. We promise we will get back to you with answering your questions. And if we don't right away, just be patient, because we're still trying to deal with patients too. So we thank you, and Dave, I can't thank you enough as well. So Linda, I'm going to turn it back over to you and let you wrap up.